Three, two, one. Welcome, everyone, and we are live for another episode of Making Orlando a Better Place. Today, we have a special guest here, Dr. Kevin Treto, and one of our colleagues here, Dr. Trey Martin, is also going to join us. Dr. Kevin Treto is a fellowship-trained vascular surgeon who specializes in the treatment of the body's arteries and veins. Dr. Treto currently is working at the Vascular Specialist of Central Florida. He's in primarily the Claremont Clinic, correct?
Correct.
You also move around. Dr. Treto attended the University of Central Florida for his undergrad degree in molecular microbiology, and then continued his training in the Ross University School of Medicine for his doctorate in medicine. After completing a residency in general surgery at Orlando Health, he relocated to the University of Tennessee for a fellowship in specializing in vascular surgery. So thank you for taking time out of your day today to meet with us, talk about thoracic outlet syndrome. And thank you, Trey, for joining us also today. Are you ready to make Orlando a better place?
Yeah, let's do it, man. Yeah. But thank you again for having me on the podcast. It's been looking forward to it.
Yeah, no problem. So we're going to talk about all things thoracic outlet syndrome today. So for our followers and for our guests or people who are watching this right now, what is TOS? What is thoracic outlet for you?
So thoracic outlet is kind of like a constellation or a grouping of symptoms that people will have from compression of either an artery or vein or nerve in the thoracic outlet. The thoracic outlet being this space or spaces in our neck, kind of upper chest arm area that these structures come or cross over. And so people will have different symptoms based on, what's being compressed, the artery, the vein, or the nerve. And there's kind of three spaces, without delving too much detail. One's up here in the neck where there's these neck muscles that can compress things. The other space is kind of between your first rib and your clavicle. And this other third space is just kind of between your upper chest and your shoulder area. So any one of those spots can be kind of a hot spot for where things can get compressed, leading to symptoms of either the arm, particularly the arm, but also the neck, the head, the chest, and back as well. So it's just a compressive symptom that causes a compression that causes these symptoms that people can experience, particularly in the arm.
Okay. Is it more of older population syndrome? Do athletes get this? What type of patients are you seeing in the clinic? Kind of does this happen to athletes? I know Trey's may have seen some people in the past because Trey works a lot with baseball players and overhead athletes. And that there are some sort of athlete conditions, but from your experience, do you see it a lot in athletes? Do you see it more in the older population? Who normally gets this?
I see it more in the younger population, particularly, and we'll go into this, depending on what type, but you see it in college athletes like baseball players, golfers, swimmers who use their arm and do a lot of repetitive motion. You'll see a particular subset of TOS in those patients, but usually a younger patient, if you take all comers, usually younger than 40, anybody over that age, I kind of question whether it is TOS. Not to say they can't have it, but it usually is a younger patient, somebody who's an athlete using a lot of overhead movement, or even somebody who's a little bit older but works on, let's say, assembly line, a construction worker using a lot of overhead movements as well. And again, depending on what their occupation is, their age, they can present with a different subset of TOS. But it tends to be a younger patient. And again, anybody who uses their arm over their head a lot.
Okay. What are some of the common signs and symptoms? Like if someone's having these symptoms, what is going to trigger them to say, okay, maybe I have thoracic outlet? What are some of the common signs and symptoms or the common complaints that if someone has this, that they'll actually experience?
Yeah. So, again, taking those, risk factors, occupation, if somebody has, a numbness, pain in their neck, let's say shoulder girdle, upper arm, any weakness in that arm as well, that they may be experiencing, and that more so for one subset of TOS called neurogenic. Other patients may have what we call venous TOS, where the veins are being compressed. And so they'll have swelling of their arm, discoloration, kind of a blue or purplish color, and pain as well. And then arterial, which is a very rare form of it, they'll have symptoms of kind of pain or coolness in their hand, They'll describe kind of this dead arm exertional fatigue with using their arm. But those patients are usually have no symptoms in their neck or their shoulder because it's something that happens more distal in the arm. So depending on what type you have, you'll present with those maybe 3 different categories of symptoms.
Is it ever on both sides, or is it just one most of the time?
It can be on both sides. I have seen people with neurogenic on both sides, which is the most common. But again, usually it presents on your dominant arm side because that's the one you're using the most. But there are some people who, let's say they work with both their hands, like people on a keyboard a lot, or kind of in a bilateral fixed position like that, where they're using both arms equally. They can present bilaterally, but it's pretty rare.
So Trey,
you like a cervical rib with patients like this?
Say that again.
How often do you see a cervical rib with thoracic outlet patients?
That's a good question. I don't see I don't see cervical ribs very often. It's very low percentage, maybe, I don't know, 10, 15%. I do see, a first rib that's very big or broad-based and has maybe these abnormal attachments on it. But the cervical rib, even, because there are a lot of studies looking at cervical ribs and they're present in a lot of patients, even without symptoms. But I haven't been doing this very long, but I don't see cervical ribs very often. I just see a very abnormal, big, large first rib that tends to cause that compression in that subset of patients that has venous TOS or the venous, the vein compression as their symptoms. So,
with your baseball guys, what are their typical symptoms that you see?
So they'll be like, either it's they'll have some kind of episode where they get a lot of swelling with their arm after they're pitching, practicing. It gets better when they rest, or at one day, all of a sudden the swelling comes on and it doesn't go away. And so at that point, the compression is so severe that they've actually clotted or formed clot in that vein. And now, even without using the arm, they have no way to drain the arm. And so it swells up because the blood has nowhere to go. So that's where I've seen the venous TOS in young patients, like athletes. They present with intermittent arm swelling, and all of a sudden the arm swelling came on and it does not go away, and they formed a blood clot in that vein.
Yeah. I was going to ask you, Trey, from your experience with overhead athletes and pitching and stuff like that, what are your kind of clinical symptoms or complaints that you've seen in overhead athletes who may have TOS?
The main thing I hear, it's probably a little bit earlier than the full-on swelling stage, but a pitcher will start saying, I just don't feel like I can feel the ball quite as normally, which that could be from a couple different factors. But one of my mentors said he thought everyone in the major leagues had TOS. They were just on a spectrum. So he's like, some people are full-blown occluded. He's like, everyone that makes it that far, though, their scalenes are going to hypertrophy so much. The first rib's going to elevate to accommodate throwing. And he was like, I believe everyone has it in some way, but that's what we would see more is like, they would just start talking about, my fingertips feel a little off. I remember reading Matt Harvey's interview. Do you remember him with the Mets? He was kind of the first mainstream thoracic outlet guy. And with him, that's what he said. Like his arm would feel dead, and he could still throw like 95, but he just started putting his fastballs right down the middle of the plate instead of locating. And it was mild though. It wasn't like his arm was blue. So that's kind of what I see more as that kind of beginning stages that I assume would probably turn into that, but it's more like a feel thing than it is like I got all this pain. And then interestingly, I'll see same side neck tension and then a limitation of rotation away. So that's the last 2 things I see more commonly. Yeah.
And I have seen, young athletes also present with neurogenic TOS as well. And so again, it's just that they're using that arm over and over again, high speed, a lot of workout. And again, they have changed the mechanics in that area and also have hypertrophied that side so much that they're getting some sort of compression. So that's not uncommon to also have, those symptoms maybe earlier on than when they come to me. When they come to me, they're usually presenting with, some sort of clot disorder, which they may also have a component of neurogenic as well and venous, because they've kind of exerted both those muscles up there and also formed some compression in the vein as well.
So you also see like malformed first ribs. Like in orthopedics, we've known there's different classifications of clavicle types and different, malformations of clavicles, but you also see there's like different variations of first ribs. some are thicker and bigger that may predispose someone to getting TOS?
Yeah, I mean, usually we see, I don't know exactly why some get this or more than others, but that costoclavicular space, the space between your first rib and your clavicle, in some patients, it tends to be very narrow and small. And there's muscles that sit right under the clavicle muscle that gets hypertrophied and causes compression there. But then that in combination with a very robust first rib further kind of narrows that space. And they'll also have kind of these weird attachments from, these scaling muscles, which are those neck muscles, they attach that first rib there. And so they'll either hypertrophy or they'll have bands that come across that cause compression not only on the nerves, but also the vein as well. And so, I very often when we do these procedures, which is kind of one of the later steps, we'll see the rib and it is very wide. And you we'll always have their arm in the field and we'll raise their arm and we put our finger into there and it just squeezes down on your finger, and it makes it very obvious as to why this vein had a very hard time draining the blood or why the nerves are so compressed and angry in there.
I'm curious with that too. Do you guys look at the opposite side too to see, is it more of a genetic thing where they just have a bigger first rib, or is it repetitive loading causes the bone to be a little bit thicker more than a normal person? Is that it more so, or is it just bad genes?
I have to assume that the rib on the other side is probably the same. It's just a matter of, we usually see on the dominant side because that's the arm they're using a lot. But I have to, we don't normally look at the other side in terms of, it's just hard to know what the other side actually looks like. I mean, you're looking at an X-ray or a CT scan sometimes, but until you actually do surgery to see how broad-based it is or what the attachments are. But there has to be something that precipitates that. Because usually neurogenic, there's either, dominant arm because you're using it a lot, or they had some kind of accident where they have neck trauma on that side, a clavicle fracture, something that makes all the things in that space kind of abnormal or hypertrophy or grow, osteophytes or something if they have a fracture. Whereas if the other side never undergoes that, the broad-based rib alone won't necessarily bring on the symptoms. It has to be that in conjunction with all these other things that kind of occur over a period of time.
Yeah. So let's touch in a little bit with, we can keep it basic too. We don't have to get into different diagnosis testing and what test you do, but how do you differentiate between artery versus venous versus neurogenic versus an orthopedic case? Is there any signs and symptoms or things that you look for that, okay, this is more neurogenic, this is more arterial versus, ortho versus artery versus vein? Anything specific that really jumps out to you for each one of those?
Yeah, so neurogenic tends to be somebody who has kind of exhausted everything because it's a diagnosis of exclusion. So they've seen a neurosurgeon, an orthopedic surgeon. They've probably even had some sort of spine surgery to try to fix this. They've had the wide gamut of tests. So that kind of leans me toward, okay, maybe this is a neurogenic kind of symptom or case. But they'll have predominant, neck symptoms, shoulder or arm symptoms. They'll also describe it like an occipital headache. So kind of very generalized symptoms in that arm. If they have just forearm hand symptoms, sometimes I think more of a radiculopathy, like a single nerve problem, like carpal tunnel, something like that. But they'll have this very generalized array of symptoms in their arm, the entire arm, neck pain in particular, and they'll be very tender in those particular spaces when you examine them.
Would a nerve, sorry for interrupting you, would a nerve medication change symptoms for a neurogenic case, like gabapentin or any kind of nerve pain med?
I've never seen that. Yeah, I've never seen that work particularly, just because I've never read anything in terms of literature or anything like that showed that it is very effective. So I've never seen it work. I see it more work of like a neuropathy kind of standpoint, but when it's more of a, mechanical stress kind of thing, I haven't seen it work. But again, those are kind of the symptoms I look for in terms of, and also their history. And then on exam, I'll do certain tests where one very easy test is you have them hold the surrender position. They'll open and close their hands. And if they can't do that for 15, 30 seconds or the symptoms are reproduced, then it's probably more of a neurogenic case. With venous TOS, they'll have the classic symptoms or, the history of arm swelling, what's their occupation, young patient, baseball player, swimmer, golfer, something like that, or a history of a blood clot in the arm. Again, doesn't have a lot of, these nerve symptoms in the arm that you more see in neurogenic. And then arterial is the least common, but they are usually presenting with something more distal because it's caused by some clot that breaks off in the arteries up here that go to the hand. And so they'll present with coolness, pain, numbness in their digits, their hand, again, with very absent or few symptoms around the neck, shoulder, chest area, because it's something that happens more distal. So that's kind of how I generally group them when I'm kind of first talking to a patient and trying to figure out, which three of these may be going on here.
Do you see any jugular compression with this stuff at all?
Usually don't. Jugular kind of sits behind all those muscles in there. And so it's really more so whatever comes across it. And so that vein, joins the jugular, but it joins at a space beyond all that. Yeah. So I haven't really seen any jugular compression, like maybe somebody presenting with like head swelling or facial swelling or anything like that. It's usually any of the structures that come across, which is either that brachial plexus, those nerves that go to the arm, the veins that go to the arm, or the artery that goes into the arm. So anything kind of comes across it.
Okay, so you don't see much like retrograde venous symptoms where it kind of kinks at a distal point and causes problems up the chain into the head and neck very often?
So no, I don't see that, but that's a good question because we do see patients, let's say if it's very chronic or it's been going on for a long time. I just had a patient recently, he's had a venous TOS for 15 years. He has these huge veins on his chest that have just formed over time to kind of compensate for that narrowing, but it drains or joins back into space where everything more central to that is draining fine. So it doesn't reflux or go back up to the head. It just continues on down to the heart. But that is something that you see where you have a compression here, and you'll see a lot of veins around somebody's chest, kind of upper chest, shoulder area, because they're trying to find other ways around that narrowing or blockage.
I asked specifically because I had this crazy case about a month ago with this guy that he had an alar ligament tear from like 12 years ago. And he went to a bunch of people, thought it was cervical instability. I was seeing him, and he met with it's some orthopedic from Europe, I think. This guy thought he had thoracic outlet syndrome causing like some type of backflow. And then they talked about, I think it was eagle sign or something like that. And they thought that was causing pressure and changes in intracranial pressure, leading to he had dizziness and some, not double vision, but he would have problems with visual spotting and things like this. But I'd never really heard of TOS being something that could go backwards more than I always thought it was just like problem here, feel it here.
Right. Yeah.
That's what they thought. So I was just curious if that was really even, when I first heard it, I was like, I don't even know this is a thing, man. And then I tried to look into the research on it, and I could really only find one guy writing about it, and it was the guy that he had seen. So I was kind of like, all right, well.
I know. It's like one of those things, once you find something, you put your stamp your name on it. I mean, that's not, because there's so many ligament, the thoracic outlet is a very tight space with a lot of things that come across it. And any sort of trauma there, whether it's, across that space or even from the spine to that space, I mean, I could see how it could theoretically cause compression on any one of those structures that come across there.
Yeah. So for the audience, we know the difference between like neurogenic and stuff like that, but some people who are watching this may not know what neurogenic means. So in a simple way, how would you define neurogenic?
Neurogenic is just when you're having, generally the symptoms caused by compressions of the nerves. And so that's the most common. It's like 95% of cases where the nerves, they go to your arm, your upper chest, your back, are compressed by either these muscles or some kind of, connections or scar tissue around that area. So that's the neurogenic, just means you're having symptoms of nerve compression. Venous being vein, you're having symptoms of vein compression, where you get that swelling, blood clots, etc. And then arterial just mean artery, where you're having, some sort of symptoms or sequela of the artery having a problem. Either it's narrowed or you're having some clots that are shooting down the arm that's causing some sort of arterial symptom. So those are kind of the general terms we'll use for describing any one of those three structures that come across that area.
So what is the best test that you use to clinically define or, to properly diagnose someone? So like we had a patient come in here and they actually had a case of Parsonage-Turner syndrome. And I've never seen a clinical case of this. He presented with all the symptoms of thoracic outlet, except significant muscle weakness wherever the lesion was or the damage was along the brachial plexus. So I had to go through research on what's best evidence to treat this stuff. But I'm sure you see a lot of different cases with differential diagnosis, but how do you confirm the diagnosis of TOS where you run X tests and then, okay, this is TOS, or is it a diagnosis from exclusion, or do you rule in and rule out some random things like Parsonage-Turner syndrome, or how do you clinically or even diagnostically diagnose that neurogenic TOS?
Yeah, I mean, neurogenic for sure is very difficult because it, like you said, it's the diagnosis of exclusion. So, I mean, the way I do it is, again, a full history and exam that kind of lets me know maybe what's going on. But there are some criteria that we've kind of developed where if you have, if you had symptoms for a certain amount of time, like 12 weeks, and you have these symptoms in these 4 or 5 different areas, it may clue me in. But, after that, I'll just get I usually get an x-ray to make sure there's, identifying the structural abnormalities. And then I'll usually get a nerve conduction study to make sure they don't have a radiculopathy or some spine problems, so that could, because if that's positive, then that can be particularly addressed by a neurosurgeon. But if those things are negative, and I'm kind of trying to still figure it out, I usually, what I've done is do a scaling block where essentially they inject a local, like an anesthetic near those muscles to kind of relax them and to see if they get relief of symptoms. And that's actually been shown to be very predictive of how well they'll do in surgery. And so that's kind of, if my history and exam is very clear cut and they have all the symptoms, then I'll maybe sometimes forego that. But if I'm kind of on the fence, I'll do that test and then kind of give me some kind of more confirmation that this is, neurogenic TOS.
What's in the scaling block? Is it
it's
like
a long
lidocaine? Is it a muscle inhibitor? Like,
yeah, it's like lidocaine. It's or a very similar medication where it's long acting. And so it's just, like lidocaine that you'll get at a dentist or a doctor's office, et cetera. And so it just, numbs up that area and kind of releases and relaxes those muscles. And it'll give us, they also use Botox as well, which is also a relaxant that just lasts a little bit longer, but it'll kind of relax that area and give you some kind of, you're trying to recreate what it would be like if you released or removed all the tension there. And the last patient I did, actually the first patient I did, she had significant relief of symptoms. And I was kind of on the fence about her diagnosis. And so I was like, okay, well, maybe this is really neurogenic. So that's how I would kind of diagnose that. The venous is a little bit easier, I guess. I usually, with that history of a clot or swelling, I'll get an ultrasound to see if there's any blood clot or narrowing there. And then either a CT scan looking at the vein will show the compression, or traditionally I'll just bring them into the office and do a minor procedure where I shoot dye in the arm and I hold their arm in those different positions and I can literally see the vein pinched kind of in that space. And then the arterial, again, an ultrasound of the arm to see how the blood is flowing, to see if there's any narrowings. And then a CT scan will kind of show me the arteries if they're narrowed or if they're what we call enlarged and have formed clot in them. And that's where all that clot is coming from and shooting down their arm. So the venous and TOS a little bit easier to diagnose because there's pretty clear-cut tests to kind of see the anatomy. But the neurogenic, you kind of have to take all those things in together to kind of piece together the diagnosis. Yeah.
We asked that question because we had a really interesting case a couple years back. This young softball athlete, pitcher, 16-year-old came in with like shoulder pain. Everyone did surgery on her shoulder. There was nothing in there, but she couldn't throw, she couldn't pitch. And it was crazy because she actually presented like a frozen shoulder. And I was like, people are going to think I'm crazy, but she presents like a frozen shoulder. Yeah. And then I plateaued with treatment. And then with frozen shoulder patients, I always treat the neck and like upper ribs also. So then she started getting better a little bit. but we kind of plateaued with treatment. And I was like, people are going to think I'm insane, but she almost has like thoracic outlet. And we tried to find a thoracic outlet. This is years before I even knew you. And she had to go to Tampa, and they did that scaling injection.
Oh yeah.
And then they used it as a kind of quantify whether she needs surgery or not. And she had like a 50% reduction in symptoms. It worked great. They ended up doing the surgery on her. Then she came back for like rehab afterwards and eventually recovered. But that's what brought that question on. I wanted to see if, like, do you see that a lot in the clinic, or does you and your team do those scaling injections? What is the injection? And then also, do they ever use it for treatment, or is it just to say, do you need surgery or not?
I've seen it, because the lidocaine, that kind of injection doesn't, or bupivacaine, whatever anesthetic they're using, doesn't last very long. The Botox may last a little bit longer, but again, it's kind of just a remedy, kind of a Band-Aid on it, just to kind of confirm the diagnosis, and it also helps predict who's going to do well with surgery. But yeah, I mean, I agree. Neurogenic it's hard to diagnose because, like you said, you had this patient who had shoulder surgery, had gone back and forth between different specialists. So it is kind of hard to sometimes diagnose. And so I'll often see these patients several times to kind of, do these different tests, do the block, make sure, I reiterate their story before I commit them to surgery, because it's not a small surgery. But the block, I think, what I've seen in some of the research and also anecdotally in the clinic is if it's positive or they have relief, that, it's kind of, very confirmatory for me that, hey, this is probably what's going on there. So, yeah.
Do you try to place the block where you think the symptoms are occurring, or is it just standard? You're picking middle scaling, right? Do you just show the same spot every time?
Well, a good question. I don't do the block myself. So I send it to our interventional neuro radiology colleagues over at Orlando Health. And the guy I sent it to, he did a lot of it, I think, up in Chapel Hill with another big TOS guy up there. I don't want to say a big TOS guy, because I'm not, don't want to label myself that, but he did a lot with him.
Yeah, it'll happen.
Eventually. And so he would, by what I read, by talking to him and what I've seen, is they try to inject it somewhere in that anterior middle scalene, one of those two neck muscles, because that's where the nerves come out from. But as far as the technical details, I'm not exactly sure, but they try to inject it in that area, not necessarily where the symptoms are going on, but more so where the point of compression is, which is sometimes remote from where the symptoms are going on.
Okay. Do they have to do that like ultrasound guided or something, or are they just that good at that point?
No, I think they're using ultrasound guidance. I don't think they use CT. I think under ultrasound, you can see pretty, I've seen ultrasound guided nerve blocks before, and it's pretty good picture where you can see the nerves and the bundles, and the needle tip is very bright, and you can kind of direct it exactly where you want to around that area. Yeah.
That's pretty cool.
Yeah.
Yeah. Let's talk treatment. So obviously the most common type is that neurogenic type, but if you had 10 neurogenic cases of TOS in front of you, what type of treatment options do they have? Do you always test the injection to see if they need surgery? Do you ever try physiotherapy? Is there a medication treatment approach? What are the top 5 or top 3 to 5 treatment options for neurogenic PT or neurogenic TOS?
Yeah. So, I mean, like I said, I'll try to treat them or confirm it with the block, but I always do physical therapy with these patients, just because it sometimes significantly improves their symptoms up front, but also they're going to need a form of it afterwards. And so I usually, we had a TOS guy where I did fellowship, but then when I moved here, I didn't really know anybody. And then we met because of, issues that, that I saw you for, but I usually try to send them to somebody who does TOS that can maybe help them with, the physical therapy aspect, not only for relief of symptoms, but even after the fact, so they can maintain that. So I usually try that for 6 to 8 weeks before I commit anybody to some kind of procedure. And again, you guys are obviously the specialists in that, but it's really, from what I've seen is, they've kind of lost some sort of mechanic in terms of their, stability or, going on in either their neck muscles or shoulder girdle, their spine. And also I've seen, with and for whatever reason, they'll have an element of breathing dysfunction. And so they're using a lot of their accessory muscles in their neck and their kind of upper chest area to breathe, which also may cause hypertrophy of that area. And so those are kind of the two things I send them to physical therapy, is to, one, correct those things to see if they have relief before we go for surgery. And then even after the fact, they're going to need a form of physical therapy to maintain that, and also to kind of recover from their surgery. So I always try physical and even occupational therapy first, because there's a lot of things they may be doing at home that's just setting them up for having these symptoms, ergonomics, how they're doing their work, how they're sitting in a chair, et cetera. So, I'm glad we've met, because now I can maybe send them all to you guys. But I always try that first, because if I can save somebody a surgery, I love to operate, but if I can do that first and they get relief of symptoms, I'm happy for them. Great. We save a surgery for never, or for some other time when things are resistant to treatment.
Yeah. When I was asking that question, I had a Freudian slip. I kept saying physical therapy. Like, it's like treatment, physical therapy. Anyway,
physical therapy.
Is it ever medically managed, like through medications at all? Or is it pretty much conservative or operative?
Yeah, so for neurogenic, there's some medications out there that they'll, is very anecdotal and not a lot of research on. So, I wouldn't even, I've never seen anybody use it traditionally. For the venous TOS, if you can clear the clot and they do fine, and you sometimes keep them on a blood thinner, they'll do okay. The last patient I saw, he was diagnosed 16 years ago, was put on a blood thinner and never had another symptom, but then they recently took him off of it, and then he recurred again. So usually, because it's a mechanical compression, there's really no medication treatment. The physical therapy, I think, works because it can change how their posturing mechanics and stuff like that can help with their symptoms. But I haven't seen any medication per se that can kind of either treat it or keep it at bay for long periods of time.
Hey, Trey, with your athlete populations and with your history dealing with baseball players and overhead athletes, what have you seen that work? Do a lot of the athletes go and opt in for surgery, or can they manage this through physical therapy and strength training and stuff like that by mechanics?
Well, I think the most effective but boring thing for baseball guys is if they just don't throw for a while, the scalenes will start to atrophy enough and they feel pretty good. So there's not a ton from that management besides like maybe trying to correct scapular mechanics, get the neck to open up a little bit more, and just try to clean up some space the best you can. But yeah, it's kind of a mix for the pro guys that were throwing a ton and needed to get back. They seem to be a little bit quicker on the trigger for surgery. And especially at that high of a level too, because even if you could take it from making up numbers like 70% occluded versus like 20%, if I get them down to 20%, they're still 20%. And if you're trying to go throw a baseball 95 miles per hour on the black, then I think with those guys, they tended to favor surgery a little bit more, especially in the Northeast where I was at the time. So we'd have a decent amount that needed the procedure, and then they rehab with us after. But normally the best thing that works first is just get them to deload from their throwing routine long enough, try to build up some accessory things, change the mechanics. I think the breathing component's interesting though. I've never really thought about that actually. So that's something I'm going to keep in the back pocket that makes a lot of sense though.
Yeah, I saw, some of the stuff that I looked up, there's this protocol called INVEST protocol, which is called, this guy, Edgelow, it's called Neurovascular Entrapment Syndrome Treatment. And he kind of goes through this 3-part where they activate the muscles. And again, I'm not going to pretend like I'm a physical therapist, but they try to activate the muscles and stabilize them up in like the shoulder girdle, the neck, the spine area. They try to emphasize diaphragm breathing as opposed to accessory muscle breathing. And then simply cardiovascular training, just aerobic training. And I don't know the details of it, but it's a protocol that they use to kind of treat that from a physical therapy OT standpoint before they commit somebody to surgery. So there is some data on it. And so again, I'm always, if it's low risk, I'm always a proponent of trying that stuff out first before we go through a surgery that has potential risk far greater than just doing therapy.
That's interesting because, it makes complete sense though. There's so many, the young generation, I believe, has such a breathing problem. They can't even take a deep breath in. I'll ask a patient to take a deep breath in, and I'm like wanting them to breathe all the way in and all the way out. And they're like,
right, exactly. Yeah. I was like, and that's probably a conversation for another day, but I've read some stuff recently on that for just whole body health. and breathing by far is something we don't do very well. But again, that's a 4-hour conversation for another day.
Did you read that James Nestor book about breathing yet?
Yeah, so James Nestor's Breathe book, that's where I got that from. He's like, we're just running around just trying to get air. Nobody's actually breathing for what's intended to be both physical and mental health. So yeah, that was a really good book.
His story when he talks about like taping his mouth and then plugging his nose and doing a self-study there, that scared me away from mouth breathing for like the last year. Since I read it, I'm a firm nose breather at all times.
100%. Yeah.
Watching his blood pressure shoot up, heart rate, everything. I didn't know it was that bad. I remember meeting with a physician. Do you know Dr. Lee by chance?
What's his first name?
I don't know that.
What's his specialty?
Endocrinology. I think he's over in next to the YMCA and Dr. Phillips, maybe.
Okay, no, I don't know him.
He was like big into taping your mouth shut at night kind of thing. When I met the guy, I'm like, this guy's crazy. Like, why is he saying this right now?
I know.
So then I read that book and I'm like, all right.
Yeah.
Not weird, but we'll look into it.
Right. So I'm sure, years from now, somebody will look up breathing, not only for TOS, particularly for TOS, but for all these other things that maybe are causing ailments. And just by breathing right, we can just kind of correct. So, yeah.
It's interesting from a treatment standpoint, from the physical therapy side of things, there's a subset of TOS patients that used to not respond to physical therapy services. And those are the ones that we try everything. We exhaust all options, but we plateau at treatment or they don't respond to treatment good. And we send them to like physicians, and that's when they did the injections. Now, what we're trying to see, I don't know if there's a study on this or not, but now with doing dry needling to the anterior and the middle scalenes, we're seeing if we can actually get rid of the symptoms and then actually get back into exercise without reoccurrence of symptoms. Because if we're just putting a Band-Aid on it, but as soon as they go back to exercise, it comes right back, then we want to be able to identify those patients and get them to you sooner. But versus getting rid of symptoms and actually return to sport or return to athletes or activity through needling that middle scalene and that anterior scalene, we're actually starting to show results with that. Really? It's pretty interesting stuff. I have a case right now that it took her 3 months before she could start exercising.
Oh, really?
And now she can exercise now without having the cold sensation down her arm, without having any compression. But it took forever. It took forever to be able to get that. Yeah. And we had to get really innovative in that treatment approach. So it'll be interesting to see if there is any studies out there for TOS patients and the effects of needling those scalene muscles and stuff, and see if it shows a long-term effect that someone can actually not only reduce symptoms but prevent it from coming back.
That's a
question. Yeah, good.
Yeah, I mean, that's a good point, because when I saw you, I was having my hip problems, and we went through all that stuff and even some dry needling stuff, and I was able to relieve the pain, but I'm still running, and so I if it's the process is the same, some people have that same process up here, for people who are athletes and stuff like that. So I can imagine if you're having those results in other muscle groups, why not up here where, you're not changing, let's say you're not removing the muscle. Nobody removed my hip muscles, but I did those physical therapy things. My pain went away. I still went back to running, but my pain didn't come back. So there probably is some truth to that. And I hope somebody does maybe somebody's already doing that study out there. It's probably even published. We're just not aware of it, and it hasn't come to let's say mainstream treatment just yet.
What is the success rate with surgery? On general, so, yours is obviously higher than the norm.
Right, exactly, yeah.
And the national average of success rate, Dr. Treto's is definitely higher than the average. But
right.
In general, is it a highly successful surgery for people who need it?
The results out there, we're not really good at keeping standardized results in terms of, this is how one person does it. So the data is kind of mixed because we don't have standardized, reporting standards, but it's pretty good if as long as you don't have any of the negative predictors of surgery, 1 to 3 months and we're talking about neurogenic, because the other ones respond pretty drastically to surgery, arterial and venous, but neurogenic, at 1 to 3 months, there's 90% success rate. And then long-term, 10 to 15 years, and some of the longer data sets I saw, up to 70%. And then some other studies looking at mid to late outcomes, if you take all the studies together, looked like 60 to 85%. So again, as long as you don't have any negative predictive factors, surgery does pretty well in terms of relieving your symptoms and staying symptom free. But again, we're also, well, what's relief of symptoms? Is it 90% better? Because we're saying you're 90% better, 90% it works if you're 70% better, so we don't, it's very subjective. And so it's kind of hard to say, well, how do you measure people having success? But on a general sense, those are kind of the numbers when you look at surgery, somewhere 60 to 85%, staying pain-free for long periods of time, being able to go back to work and stuff like that.
I always hate
that it doesn't work for.
What was that?
What happens to the ones that it doesn't work for? What do they do after surgery?
So some people will, it depends on their symptoms. Some people will reoperate on them, depending if they find that it was an inadequate decompression. There's other points along or different spaces where you can release kind of some of the spaces as well to see if that gives them relief. I've seen patients where they have TOS symptoms, you decompress them with removing those scaling muscles in the first rib, but they're still having some kind of radiculopathy. And so we'll go to this other space kind of between the shoulder and the chest to relieve the muscles that are kind of compressing things there as kind of a last resort. And so, and also, again, trying physical therapy even after that. But, that's why in the first operation, you want to just make sure you do a full extensive, what we call decompression, to try to maximize the outcome. And then maybe another procedure to try to, give them some other hope of trying to relieve another point of compression. Maybe that's where their symptoms are coming from. But I think those are really hard patients to kind of manage, those that have already had surgery and then they're still having persistent significant symptoms, their symptoms come back.
But you also said this earlier, that injection into the scalene is a positive response to that injection shows a high probability that they'll benefit from the surgery, correct?
Correct.
Yeah.
Go ahead. Sorry, go ahead.
That was spoken correctly, right? So for like people who maybe watch us who have this or told that they need surgery, they need to go try that scalene injection, because if they have whatever the qualification is, a 50% reduction of symptoms or more with that injection, that shows a high probability that you may benefit from the surgery, correct?
Correct. Yeah, I think it's around 70%. There'll be a positive responder to surgery because it's kind of confirmatory that, hey, it is the scaling muscles. And so if we remove those, you're probably gonna have relief symptoms. So that's why, if they're on the fence about surgery and I'm not clear cut on their diagnosis, I'll get that to see. It'll tell me that they're going to respond positively and have relief after surgery.
Perfect. Do you have any other questions, Trey?
Yeah. Do you ever see someone that has like a combo of where it's more of a cervical radiculopathy with TOS at the same time and it kind of blends together?
Yeah, I have seen some patients get, I have my last patient I treated, she had spine surgery and she got some relief, but still had significant symptoms. And so at that point, and she had an EMG study showing that she had a particular radiculopathy, meaning she had a nerve root that was being compressed. So she got better somewhat, but then I think once she got better from that, she was so focused on these new symptoms that it almost seemed like she reverted back to where she was before. But I have to assume that she got better from that. But now this is what was also bothering her as well and became so focused. And so I decompressed her and she got significantly better. So I think some patients do coincidentally have a component of both a kind of single nerve root problem from the spine and some TOS, kind of all the nerve root symptom. Yeah.
Perfect. Any other questions, Trey?
No, this has been great.
Yeah.
Perfect. So we're not going to let you off that quick, though. We got the Fab 5 questions coming. So are you ready?
I'm ready.
Okay.
These are the hard questions.
So the first one is, what is your favorite restaurant in Orlando?
I have to say this is it because I eat there so much. It's this place called Hungry Pants. It's actually Soto area, like Michigan and Orange Avenue. It's like this plant-based, because I'm plant-based, restaurant where, and I think it's local as well, where they have, because everybody always thinks about plant-based tofu and it's like, oh, that doesn't taste like anything, but they actually do a really good job of preparing it. A lot of that stuff is clean, organic, like farm to table kind of stuff. And it's close to my job. So that, I say that because I eat there the most throughout the week. So that's probably my favorite restaurant right now.
Yeah. we have like a running list right now of the top restaurants, and normally you'll get like Enzo's on the Water, you'll get Hillstone, you'll get Kabuki Sushi, which we tried recently. Kabuki Sushi is really good.
Yeah, they're really good. Yeah. It's hard to get a table there, but it's really good. And the other place I went to that place, Hunger Street Tacos, that you had mentioned to me.
Oh, you did? Yeah.
I'm like right now in a Mexican phase, or Mexican food phase, I should say. And so that place is also really good. That I'm kind of between there and Hungry Pants been eating a lot.
Oh,
These
nice.
are all people that have not been to the Strand, though. If you went there, it'd be your favorite place.
I have been to the Strand. It was a long time ago. I may have to go back there. It's been like 5 years since I've been there.
It's way better than Hungry Pants and Hunger Street.
Okay, we'll have to go check it out. All right. So number 2 is, what is a under the radar small business or local business that you want to help promote and promote awareness of?
So I live over in Baldwin Park, and I don't know if it's under the radar, but it's a small business, is the whole East End Market kind of area over there on Corinne. I mean, that place is just awesome. They have, Winter Park Biscuit Company, I think Lineage Coffee, Farmhouse, all these kind of, local restaurants there and under one roof that good, really good food. And it's a nice, like, local feel. And they also have some, I think, a wine shop there, some furniture store. So I know it gets really busy on the weekends, but I think because I live there and I like the whole setup, that's one place where I would say everybody needs to go check out at some point. Domu is another good restaurant there that has a lot of like ramen kind of style food. Nice. So everybody go check out East End Market. It's a pretty rad place.
There's a little cocktail bar on the top now too that's pretty good.
Oh, really?
Yeah, and they have a tasting menu, I think, with the restaurant across from it. They just opened it probably 2 months ago, I think.
Yeah, that's
Gideon's cookies though.
What was that?
Do you try Gideon's cookies? Have you seen
I have tried them once, and I stay away from them because I will eat them all. So if anybody wants a good cookie, go to Gideon's Cookies. But I didn't know they had that up top, so I'll have to go back there and check that place out.
So on average, how many hours of sleep do you get a night?
Mm-hmm. Well, I try to get seven. I think 7 hours is the ideal for me, 7 to 8. Just because that's when I've noticed that I feel the best and I'm not cranky the next day. I feel rested. So for me, I probably have to plan for 8 so that I get 7, because I know there's some margin there. But that's what I've found over my 30 years of life trying to figure out my sleep cycle, that I function the best after like 7 or 8 hours of sleep.
Yeah, I'm a 6 to 8er. I have to get 6 to 8. I feel like I'm going so hard all week that if I get anything less than 6, I'm like not feeling optimal. I'm not feeling great. I always envy those, like my friends I have that work out hard. They work hard. They can like function with 4 hours of sleep. They can stay up till 12 o'clock reading, and then they sleep for 4 hours, wake up, read more, do something. I'm like, I wish I could do that. You can get so much more done. I just can't function.
Yeah, I'm not. My REM cycle's not that short, or my sleep cycle's not that short. I need like a full 8 hours. But
what do you, Trey?
I have to be in bed for about, kind of like he said, if I'm in bed for 8 hours, I probably sleep 7. My Whoop strap tells me I'm more at like 6.5 to 7, but I feel great if I actually get a full 8. Past that's too much, so I'm drowsy all day.
Yeah, I'm the same here. So my Whoop is what I use a lot, and it's just like for people listening, a fitness tracker, and that has been the game changer for me to regulate my sleep. Before, I didn't really know what the hours of sleep were doing for me. Like if I got 6, 4, 8, but now seeing some feedback, I'm like, okay, I need to get 8 hours of sleep.
Yeah,
and I feel it the next day as well.
What's your recovery today? Do you know?
68%. Yeah.
Oh, I got you. I'm at 85, I think.
I'm in the green, baby. I'm in the green.
I noticed with that thing, it's made me not want to drink ever again, because even like 1 or 2 drinks, I'm down in the 40s. 3 or 4 drinks, it's like 1%. Are you even alive right now? I'm like, this
exactly.
is not good.
And again, not that I'm an alcoholic or anybody here is, but agreed. Like it keeps track of certain things that you do throughout the day to tell you what your recovery is. And drinking even 1 drink or 2 is the number one thing that just drops my recovery and makes me feel horrible the next day. So I used to have a glass of wine or, have a few cocktails on the weekend. I even try to avoid that just because I want to be green the next day, and I just want to feel better.
That's interesting. So obviously it's not measuring alcohol, but it's measuring the effects of what alcohol does to your body that gives you a lower rating then.
Yeah, it monitors, and I see it. My heart rate goes up when I drink alcohol by like 10 or 15 beats per minute, and that in and of itself is how they calculate this recovery score.
Oh, interesting.
Yeah, and so I see my heart rate go up significantly after alcohol, and I know it. When I go to sleep, I can feel it, but then I feel really bad the next day. So when it uses that as a predictor of what your recovery is, or one of the measures. Yeah.
It also measures heart rate variability really intently, which I don't think is an exact science yet, but my understanding is the higher your variability, the better your cardiac fitness, the better you recover, all that stuff. I think there was a Harvard study on it recently that I looked into that, but I couldn't find like what a norm is. Like, I don't know if 100 heart rate variability is good or 40 is good. I think it's kind of all based off of you. Yeah. But if your heart rate variability is low, which it always is after, like, you can literally have 1 5-ounce, like, American Heart Association approved glass of wine.
Yeah,
you're not going to be in the green.
100%. It's in the red.
It doesn't happen.
That's funny.
If I to it, I have like questions. Did you have a drink last night? I'll put no, and it's like 40% recovered. Go to bed. Like, all right. So it knows.
That's
you
funny.
can't even lie to it anymore.
I know. Indeed.
That's perfect. Last question: what book are you reading right now?
Ooh, that was a good question. Angela Duckworth wrote a book called Grit. It talks about passion and perseverance. It's just a good book that I had heard on a podcast, and I was like, kind of, I was like, what can she actually say about this? But it's actually really good. She is, goes behind the science behind it, and how, we see athletes and we think they're born with talent and they were just gifted, but you don't see all the hard work they put in. And, in a nutshell and in general sense, hard work outweighs talent every single time if you want to be an athlete, career, whatever the case may be. And so it's just really interesting to see from, even for me, who, like, I know I'm not the smartest person in the world, or anybody, you don't have to be the smartest, but if you just outwork everybody, you can become very successful in whatever you do, whatever you put your mind to. So Grit by Angela Duckworth. I definitely recommend. It's kind of what I'm reading right now.
Well, perfect. Thanks again. We're pretty much maxed out on time.
Yeah.
Thanks again for taking time out of your day. If anyone wants to try to find you or is struggling with TOS and wants to schedule a consult with you, how can someone find you?
Yeah, so our practice is called Vascular Specialist of Central Florida, and the website is simple. It's arteryandvein.com. They can go there and learn some stuff, because we have some information there, and then also make an appointment or learn more about the practice. And then I have an Instagram account, Kevin Treto MD is my account. They can find me there if they want to send me a message or see what I'm doing lately, which I just started it up. They can find me there as well. So either one of those places, Kevin Treto MD or arteryandvein.com. Perfect.
I'll put the links to everything below the video here and stuff like that. We'll have to have you back on and talk about vegan athletes training with vegan and the whole science behind it, because I know that's a hot topic for you and stuff like that.
We'll get back together and maybe talk about breathing, and then talk about plant-based diets.
Yeah, just go injure yourself and come back and see us, and then we'll start talking about it.
Well, I will. Trust me, I got a run coming up, so I will probably see you here in the next few months.
Okay, but perfect. Thanks again for taking time out of your day and making Orlando a better place.
Likewise. Thanks, guys.
We'll see you, Kevin. Yep.